Good afternoon, all. We're continuing on with our lecture series. I had recently, I think, done a lecture on pain management after spinal cord injury. Today, we're going to focus specifically on upper extremity management after spinal cord injury. As we go through this, we're going to discuss upper extremity overuse syndromes. That'll be musculoskeletal as well as neurological. We'll talk through upper extremity clinical and radiological anatomy. I think it's especially important for our PM&R residents to recognize the upper extremity overuse issues with our folks. Typically are going to require more aggressive interventions, and so we'll talk through that a little bit. Talk through indications and contraindications for injections of upper extremity problems. And again, talk through some of the anatomical landmarks and techniques for upper extremity injections, as well as I want to talk through a little bit of, if we're going to do a surgical intervention, what that is going to look like for a person with spinal cord injury who uses their upper extremities for mobility. So have a lot to cover. I'll be running through fairly quickly. Most of this discussion is going to have to do with nociceptive pain above the level of spinal cord injury. And so certainly we can see that with spine degenerative changes above level of fusion, but sometimes as well below the level of fusion. And then we have these concerns especially to worry about for our manual wheelchair users: rotator cuff impingement, epicondylitis, de Quervain's tenosynovitis, metacarpal phalangeal dysfunction, and then myofascial pain associated with that. So how frequently does this occur? More than 80% of the time in both persons with tetraplegia as well as paraplegia, the chronic spinal cord injuries. And so at least 80% will report significant upper extremity pain. 78% both tetraplegia as well as paraplegia will report significant shoulder pain. And that's based on relatively recent work put together by Kentar et al. So in 2005, the Paralyzed Veterans of America put forward the consortium guidelines for preservation of upper extremity function following spinal cord injury. And the real key here is prophylaxis. So doing appropriate home exercises, including neck and scapular stabilization exercises, internal and external rotator strengthening exercises. Particularly, that's going to help pull the humeral head down and away from likely impingement. And then optimizing range of motion positioning as well during sleep, and minimizing noxious stimuli. So the treatment for musculoskeletal pain, typically rest, ice, compression, elevation, and drugs, judicious steroid applications we're going to be discussing, and then potentially surgical options as we go through this. So compressive neuropathy occurs in approximately 2/3 of our folks with chronic paraplegia who are manual wheelchair users. Ulnar neuropathy and median neuropathy occur at similar frequencies. The ulnar neuropathy most likely at the cubital tunnel at the elbow, but Guyon's canal also often affected through overuse of wheelchair propulsion. Median neuropathy, carpal tunnel syndrome particularly, is present again in a large number of these folks. And we have to remember that, for fitness, for general fitness, able-bodied individuals who are using their lower extremities primarily for walking, running, etc., we're recommending, 10,000 steps a day. So to maintain fitness and to be similarly active, a manual wheelchair user is also going to be putting forward, but instead of steps, we could talk about wrist strikes on the push rim. And so that's going to be upwards of 6,000 pushes per day. So you can see how that can translate relatively quickly to upper extremity overuse and neuropathies, mononeuropathies, both ulnar as well as median neuropathies. So managing neuropathic pain above the spinal cord injury, the level of injury. Again, typically we use these things, and I've talked through these last week to a large extent. We're going to, as much as possible, try to prevent. So we'll use heel bows at the elbows to provide some padding and less likelihood that you're going to have continuous involvement of the ulnar nerve at the elbow in particular. And then we have to make sure that we're using so our propulsion is going to be appropriate, our transfer is going to be appropriate to minimize upper extremity overuse. So a lot of studies, and actually fairly recent ones, these were all put forward in the 2005 Preservation of Upper Extremities Guidelines, but you can see quite a few having to do with carpal tunnel, ulnar mononeuropathies, shoulder pain, etc. The numbers have only gotten worse, unfortunately, over the past 16 years. And so we're actually seeing these in significant quantities for both folks with tetraplegia as well as paraplegia. The overall recommendations are these. Our routine assessment, as we're seeing these folks in our clinics, needs to discuss their function, ergonomics, including their wheelchair propulsion and transfer techniques. We need to consider what kind of wheelchair and or transfer device they're using, and then their level of pain, as you would expect. So we want to try to quantify that and determine if there are mitigating factors, putting it forward. Those folks who are going to be at high risk are the ones who are doing a lot of non-level transfers per day, who are using inappropriate equipment or techniques, those with heavy wheelchair weights, as well as heavy body weight. So the two of those are going to significantly increase the amount of force required to propel the wheelchair, for example. So we'll talk through a little bit about the wheelchair setup and propulsion techniques. We want to try to minimize overhead activities as much as possible to reduce the wear and tear at the shoulder, and particularly rotator cuff. And then have an appropriate exercise program that is going to prevent upper extremity overuse. So let's talk about wheelchair positioning for just a moment for propulsion. I want you to focus on the middle figure here. So option B, in which the elbow is approximately 100 to 120 degrees at the center of the push rim as they're getting ready to push. You can see in figure A, this person's seat is sitting too low. And so this angle is too acute, and it's going to increase the wear and tear at the wrist, the elbow, as well as the shoulder. Figure C is just the opposite. Now their seat is too high, so you don't have as much problems, except that you can't get much propulsion when you're sitting this high. And so you're going to have to hit many times more frequently than you would otherwise. So the ideal is to have an ultra lightweight wheelchair. This is for any of our folks with spinal cord injury who are going to be using a manual wheelchair, with moderate seat height and a raised and forward axle. Now, as you move the axle forward on the chair, you increase the tippiness. That is, they're not going to be as stable, but it also allows them to maneuver much easier as we're going through this. So the wheelchair propulsion biomechanics, and if you're not sure, take a look at some of our new users, new wheelchair users who you're sending down to the therapy gym from the acute service right now, and notice how many of them are using the contact and release figure B. So basically they're doing very short but multiple hits on the wheelchair, and they're not getting the full propulsion nor range of motion at the shoulder. And so these folks, if they continue this type of a propulsion biomechanic, they will ultimately end up with their shoulders being somewhat protracted, and they'll have tight chest muscles across there, and they're going to end up being particularly at risk for shoulder dysfunction and these mononeuropathies that we're talking about. So the ideal instead, and you can start coaching them as an inpatient, but certainly as an outpatient as well. Long, smooth strokes that limit the high impact on the push rim. So you start back a little bit further. In order to move this, you're going to have your hand drift downward below the push rim when it's not in contact, so that you have this semicircular pattern. This reduces your stroke frequency. It increases your push to recovery time, and reduces the angular joint velocity that you're going to be dealing with. So again, try this yourself, but certainly encourage our folks in the acute as well as the post-acute and then chronic settings, so in the outpatient clinics, for example. Transfers. The other very likely place to cause impingement is by doing inappropriate transfers. So perform level transfers if ever possible, and use a sliding board. Even those folks that don't feel like they use it or need it should be using this, because in the long run they're going to be using, hopefully, their manual chair for several decades. So we want to avoid impingement as they're doing their transfers by avoiding internal rotation, okay, that puts particularly the supraspinatus tendon at risk for compression. You want to avoid shoulder flexion and abduction as much as possible. So avoid the hands on a flat surface if you can use a neutral hand grip, and then vary the technique used and the arm that leads, okay? So now getting in and out of a car, you don't have many options. You got to get in. But if you're going to be getting in and out of chair, in and out of bed, alternate the sides that you're transferring to and from, so that you're having approximately equal compression, and that will reduce the likelihood for upper extremity overuse. You want to try to, so I'll say avoid trapeze bars if you have other techniques available. You can use the Arjo lifts, those types of things as well, to facilitate transfers when you have them available. But we want to try to minimize the amount of time that folks have their arms up over their head, because that's going to put them at higher risk anytime they do that for shoulder joint dysfunction in particular. So prophylactic exercise. Again, the ideal here is, you remember this is our typical prescription, so we're going to be listing the diagnosis and comorbidities, and then we're going to be listing their goals. So in this case, the goal is to try to preserve upper extremity function and yet increase resting metabolic rate. How do we do that? We want to appropriately strengthen muscles so that we increase muscle mass and therefore increase resting metabolic rate. But we don't want to do that in a way that is going to put them at high risk. So we're going to be doing scapular stabilization exercises and using internal external rotator exercises. These are the shoulder depressors to help pull the humeral head down and away from the AC joint. Lat pulls can be helpful, but again, you don't want to overdo the weight. Chest press, horizontal rows, and then biceps and triceps curls. Limit the overhead press. Not only does it increase the stress and strain on the wheelchair, but it increases the stress at the shoulders in particular. So ideally, the intensity as you get these muscles strong enough is more than 65% of a 1 repetition max. And you're going to be doing this 2, maybe 3 times a week. 1 to 10 repetitions, 3 to 6 sets, with recovery being 2 to 3 minutes between each set. You also want to make sure that they are doing appropriate stretching of the anterior chest and shoulders, and then periodization. If they're going to be doing this for a competition, for example, you're going to be alternating this as we go through there. So there's not a lot of good data out there on resistance training in spinal cord injury. That said, Dr. Nash here at the Miami Project and his crew over the years have put together circuit training, which can be very, very helpful. I just, again, encourage folks to minimize upper extremity overhead activities. But if you actually look at the literature that is out there with regard to resistance training, there's not much. They did pectoral isometric exercises over a period of 12 weeks. Stan back in '89 reported this with some improvement from the person's perspective, but it wasn't really, they didn't actually quantify their ability, their strength, or their power outputs. Wise in 2000 looked at 4 individuals with cervical spinal cord injury, and after a year of exercise training, those folks reported that they felt that they had increased independence for activities of daily living, recreation, and overall independence, and their body image was better. But again, not much in the way of quantifying metrics as we would expect in other able-bodied interventions. Duran reported out in 2001, he had 13 folks with thoracic spinal cord injury, Asia Impairment Scale A, over 4 months with 120 minutes of exercise 3 times a week. Those exercises included, quote, mobility, coordination, aerobic strengthening, and relaxation exercises, but they didn't really quantify the interventions much beyond that. Nonetheless, folks reported improved functional independence metrics, improved strength, and aerobic fitness. Hicks reported out, these are Canadian colleagues up in the Great White North, in 2003, 9 months of exercises twice a week in 23 individuals, so almost 24, with injury levels between C4 to L1, Asia Impairment Scale A all the way to D. So you can see there was a very heterogeneous group here. Nonetheless, this was a prospective randomized controlled trial that demonstrated 1 repetition max strength improved in those in resistance training versus control groups, with somewhere around 30% increase on upper extremity muscle strength and an 80% increase power output with arm crank ergometry. So if we're going to provide upper extremity exercise, we need to make sure that we're using appropriate equipment for these folks, including the wheelchair and seating systems. So ideally, our recreational therapists, physical therapists are working closely with us and our athletes, making sure that we have as well appropriate clothing and limb protection, abdominal binders for those folks who need that, and leg wraps. So particularly those who are going to be doing high intensity interval training, for example, need to make sure that they don't become pre-syncopal or syncopal because of circulatory hypokinesis. Folks with tetraplegia are going to need modified grasp equipment and or techniques, and then to make sure that they have accessible resistance training equipment and recreational therapists who know how to manage them. So there are a number of things that we can do to facilitate grip for our folks who have tetraplegia. There are gloves, there are different grip devices that will allow them to optimize their function and minimize the wear and tear at the wrist, but still allow them to participate. Now I want to switch gears a little bit and talk specifically about some different pathologies in the upper extremity. So the shoulder girdle, you all know, 3 joints and an articulation. It sounds like a singing group, but it's not. So 3 joints, including the sternoclavicular joint, the AC joint, and then the glenohumeral joint, as well as the scapulothoracic articulation. These are all pivotal, so to speak, to maintain good upper extremity function. Just as a reminder, everybody should be getting pretty comfortable with your x-rays at this point. But just as a reminder, as you're looking at the shoulder joint and articulation, you want to be looking, obviously, the humeral head, recognizing where the lesser and greater tuberosities are. They should be sitting, the humeral head should be sitting into the glenoid fossa appropriately. You're going to see the coracoid process, the distal clavicle, and the acromion, so the AC joint right here as we go through there. This is the view with external rotation and an AP view. Internal rotation is going to shift things so that the lesser tuberosity now is going to be coming more medially. You're going to see the greater tuberosity back out to the lateral side. Again, preservation of the glenohumeral joint, and you want to see some space between the acromion process and the humeral head. The other view to consider is the axillary view. So as you're looking at the humeral head and its relationship with the glenoid fossa, coracoid, and the acromion processes, just to kind of keep your bearings. That said, let's talk through this. I want you to open up your mics for a moment and tell me what you think you see here. I'll give you a hint. This is not normal.
So a fracture at the neck of the humerus is what I see.
So proximal humeral fracture. The NEAR class, excellent. Thank you for helping me out there. The NEAR classification for humeral fractures include, there's simply articular fragments. If you have the lesser tuberosity and the subscapularis involved, the greater tuberosity and the supraspinatus involved, and or the humeral shaft. So if you have minimal displacement, then they talk about using 4 weeks of immobilization, and then passive range of motion and active range of motion in that order in the progression. If you have 2 to 3 fragments and displaced fractures, then you're going to need to go with open reduction internal fixation, and then move back into this 4 weeks of immobilization as you go through there. If you've got 4 fragment fractures, you're going to need to have a humeral head prosthesis, because this simply is not going to heal even with ORAF. So what do you see here? Again, open up your mics, feel free. I don't see a fracture this time.
I see an inferiorly subluxed or dislocated shoulder.
So dislocated, excellent. And I guess it's kind of hard to tell. If I gave you an axillary view, it would be a little more clear that this is an anterior glenohumeral dislocation. So on X-ray, you're going to have inferior displaced humeral head, as Dr. Acosta pointed out. From the lateral perspective, you're going to see an anteriorly displaced humeral head. Most of these are subcoracoid, so they sit just below the coracoid process. You have some that are subglenoid, and even fewer that are subclavicular, so they pop all the way up to here. So generally, this occurs because of forced abduction and external rotation. And so as the person presents, they appear to have a prominent acromion. They'll be guarding, they'll be holding the limb in abduction, externally rotated slightly, and again, supported with the opposite extremity. Reduction techniques. This I've never seen work, but it's a nice picture, and it's in the Netter diagrams. This is basically the Stimson process here. And generally, you have too much co-contraction going on for this to actually work. The Rockwood procedure is usually what is used to reduce these. And so you have the person supine, not prone. You have a swath at the torso and the axilla. So this is a sheet or a towel. and then you provide inline traction at the affected arm. May require slight internal and external rotation as you're doing this. Dependent upon the person's pain and their muscular strength, you may have to sedate them in order to reduce this and get it back into the socket where it belongs. So management, once you get it reduced, is to immobilize for approximately 3 weeks, provide rest, ice compression. It's hard to elevate the shoulder, don't try, and then drugs as necessary. Codman's pendulum exercises begin slowly and with small circles. Then you're going to progress to isometric exercises, particularly strengthening the internal rotator muscles and the adductors at about 2 weeks. Moving on to TheraBand exercises, isokinetic exercises at 4 to 5 weeks, focusing on the anterior musculature. Now remember, what happens here is you have disrupted the ligaments. And so it's rare that those ligaments totally scar down, but that's why you're immobilizing for the first 3 weeks. You're hoping to develop some scar tissue. If those ligaments become too stretched, in other words, you've had 2 or more dislocations, then it's possible that you're going to have surgical intervention to tighten those up again. So what are we seeing here? Well, the other was an anterior dislocation. What would Dr. Gator try to throw at me this time?
Posterior dislocation.
Ah, Dr. Mzambwe makes it even more clear as you're taking a look from the axilla. So posterior glenohumeral dislocation. This is a fall to an adducted, internally rotated arm. And so now you've got a prominent coracoid anteriorly, but posterior fullness. Generally, again, you're going to see significant guarding. So the X-ray is you're going to have a narrow joint space. On the lateral view, you can clearly see a posteriorly displaced humeral head with respect to the glenoid. Not quite this easy just to push down and put it forwards. Usually you're going to have to also provide some inline traction, but you are going to be providing posterior pressure at the humeral head. Immobilize again for 3 weeks to try to tighten the ligaments up. Know that there's going to be some scarring there, and then move forward with Codman's pendulum exercises, isometric, progressing on to ultimately isokinetic exercises as you go through here. So again, these are the shoulder ligaments that you're going to be worried about. So you've got the AC ligaments, you have the coracoclavicular ligaments, the coracoacromial ligaments, and then you've got the sternoclavicular and the coracoclavicular as you're looking through these. So disruption of those ligaments is going to cause significant problems. So what am I showing you here? I'm showing you something that looks as if there was a disrupted ligament. And what I want you to be trying to piece together is the acromioclavicular ligament and disruption with that. So this is typically a blow to the acromion falling on elbow or an outstretched hand with an upwardly displaced clavicle. Wasn't as easy to tell from that previous one, I know. Generally speaking, we list these as grade 1, grade 2, or grade 3 sprains. So a grade 1 sprain, you don't see a significant disparity between the level of the AC joints. A 2nd degree sprain, on the other hand, you're going to see a 5 millimeter displacement, and a 3rd degree sprain is you're going to see a 5 millimeter displacement of the clavicle relative to the AC joint, which is going to reflect AC joint complete tear, and typically the coracoclavicular ligaments are going to be torn as well. So again, the conservative treatment is recommended. The only time that you would consider going otherwise is if you had a significant fracture associated with this as well, or cosmesis. So you're an actor or an actress and you want to try to make sure that that looks symmetric from side to side. The problem with doing these surgical interventions is that usually you develop degenerative changes over time and you have to go in and remove the hardware. So otherwise, the exercise program to get this person back, or the therapy program to get this person back to full function, again, you start off with sling immobilization and then pendulum and range of motion exercises, moving on to strengthening exercises. So rotator cuff injuries, very likely in our folks who are wheelchair users. Typically, this is caused by overhead throwing, overhead reaching, overhead lifting. And so typically on physical exam, you're going to see impingement sign, and the drop arm test tells you what? If you drop the arm and they can't hold it there, so you probably have a complete tear as opposed to a partial tear of the supraspinatus tendon. On X-ray, you're going to see potentially ectopic calcification, greater tubercle degenerative joint disease. On MRI, you're going to see some edema, calcification, and or a complete tear. So this is your supraspinatus tendon. It should look good. If it's torn and dysfunctional, obviously you're going to have to make some decisions on whether or not you can manage this conservatively, or they need to have a surgical repair. Surgical repair. So let's talk about that for a moment. If you're going to have surgical repair of the rotator cuff tendon, you need to recognize the person is going to require approximately a 6-month recovery, which means that they're not going to be able to use their usual transfer techniques or wheelchair propulsion. So these folks are going to necessarily require a power chair and a power chair with tilt capacity during the time that they're healing from the surgery, or they will likely to develop pressure injuries, et cetera, as we go through this. So there requires a fair amount of discussion with you, the orthopedic surgeons and the insurance companies, making sure the appropriate equipment is available, making sure that they have appropriate assistance to facilitate transfers and those types of things during the healing process. Otherwise, you're likely to either compromise this or, as I said before, develop significant pressure injuries, et cetera, which we would try to keep away from that as much as possible. So when do you do joint aspiration? So I'm bringing this in because we're looking at other parts of the joints, other joints as well. So elbow, wrist, thumbs, etc. Occasionally, you're going to want to do a joint aspiration. You're going to send synovial fluid if you think that there's an infection or that you have a crystalline arthropathy. What is that? Gout or pseudo-gout. So occasionally, you're also going to be doing injections for joint decompression. So not injections, but aspirations as you come through there. So indications. So for an injection, diagnostic pain relief. So for example, you're trying to determine costochondritis versus angina. Probably not so much in our spinal cord injury folks, you're going to know. Or an occipital trigger point versus migraine, for example. These are just general indications for injections. Therapeutic intervention could include you're trying to determine a diagnosis. And so you're going to be doing aspiration to determine if this is a crystal-induced arthritis or an infection, for example, and then non-articular disorders. So as we look through, I'm not going to, you get a lot of outpatient coaching on these things. I'm just going to say you're going to choose your steroids. And for me, I like dexamethasone. It's a long-acting steroid, and generally speaking, this is what I typically am using with my folks with upper extremity overuse or bursitis types of scenarios. So find the steroid of choice that you like to use, and then recognize the relative potencies as you're putting it together. It's going to indicate how large a dose you're going to provide as well. So anyway, I'm going to jump ahead because you see this a lot. Contraindications for using corticosteroids are listed here. Again, we recognize that there are some adverse effects of steroids, and this needs to be discussed in your consent, your informed consent, before you actually do an injection. When and if you get the consent, you want to make sure that you have all of your materials available, so that it's right there, I'll say at the bedside, or in the outpatient clinic scenario. Make sure that you've got these moving forward. Typically on larger joints, I'm going to use 1.5 inch 25 gauge needle for the injection itself. Use an 18 gauge for aspirating the medication. Typically, your smaller cc's generate more your smaller syringes are going to generate more force, and so recognize, typically if I'm going to do a shoulder injection, even an elbow or wrist injection, I use a 10 cc syringe. The smaller syringes, you generate more force and can actually be more painful as you put those together. And I typically am doing a diagnostic therapeutic injection, so I'll include lidocaine. That will tell me within 15 minutes, 20 minutes or so from the injection whether or not I'm successful in terms of my diagnosis and the treatment. So the corticosteroid, typically, if I'm using dexamethasone, is going to take 2 to 3 days to take hold. And so you got to warn the person who feels so much better 15 minutes after the injection not to overdo it in the next 24 hours or so, or they're going to significantly flare this up, and they won't get significant benefit for another couple of days. So they could be in a lot of pain in the interim. So pretty picture. It's not actually accurate in terms of how this needle is being put forward into the subacromial bursa here. Typically, I'm going to go posteriorly and then direct the needle slightly upward at about a 10 to 15 degree angle. This is really a fun injection to do, both for you as well as the patient, believe it or not, because of the relief that's typically associated with this. So as you get your needle in, you're going to aspirate, make sure you're not in a vascular space. And then typically I will put in 2 to 3 cc's to the subacromial bursa, and have them recognize they need to kind of take it easy. So they can't overdo for the next 3 to 5 days. And then we're going to slowly increase doing internal, external rotator exercises to try to strengthen the shoulder depressors over time as we go through there. I'm not going to have enough time to run through all of these with a lot of detail, but just recognize if you've got a positive scarf sign, that indicates that you got AC joint inflammation. So with my manual wheelchair users, I'm not as conservative as I am with able-bodied individuals. So I will recognize we can try NSAIDs and ice in the short term, but after a week or so, if I'm not seeing significant improvement, I'm fairly aggressive about getting in and doing an injection to try to optimize their functional recovery as we come through this. Sternoclavicular joint inflammation, again, relatively small dose for this as opposed to like a bursa. So using just a 0.5 cc of lidocaine and 0.5 cc of dexamethasone into the space, 1 week relative rest, and then start to move forward with range of motion and then strengthening exercises. Adhesive capsulitis, you know that the shoulder is one of the quickest joints to develop adhesive capsulitis in. And so recognize that range of motion is going to be important for our folks. We have a lot of wheelchair users who develop shoulder pain, stop ranging their shoulders, and subsequently develop significant adhesive capsulitis. And so doing a posterior injection for these folks can be helpful, but sometimes you have to move forward more aggressively and actually put them under anesthesia to break up the scarring and adhesions from these tightened capsules. Biceps tendonitis often accompanies subacromial bursitis and impingement of the supraspinatus tendon. Again, this is one where you don't want to inject into the tendon itself, or any tendon for that matter, but if you can put your medication in the sheath that this is going to be running through, then that will help to reduce the inflammation in the area as you go through there. Again, recognize that the Popeye syndrome typically comes about because of a weakened tendon, and oftentimes associated with one or more injections to the tendon, usually in those of us who get a little bit older as we go through and don't quite have the healing capacity otherwise. Nonetheless, biceps tendonitis is demonstrated through Yerguson's sign. So this is basically trying to supinate and flex the elbow. If that causes tenderness up at the long head of the biceps, you know that that's a bicipital tendonitis, and generally is going to respond well to an injection to the sheath, not to the tendon. Imaging the elbows. So again, just stepping away for a moment, and I don't know how comfortable you are with all of these upper extremity films, so I like to just throw it out there the first time you see this. The x-rays you see in the clinic aren't actually going to be labeled like this. You realize that, but nonetheless, for me, I'm just trying to remind you that you've got the end of the humerus, and then you've got the ulnar and the radius, basically, that you're going to be coming together. So it's three bones in a joint, basically, as you're looking at this. And again, I don't have enough time to go into this in a lot of detail, but recognize that elbow joint inflammation comes up not quite as frequently as we see shoulder dysfunction, but fairly frequently in our folks that are using manual wheelchairs. So trauma and overuse can contribute to this. Again, getting the needle just in that right spot makes all the difference. Using a relatively small dose, but approximately 2 cc's of 1% lidocaine and 1 cc of 4 milligrams percent dexamethasone, right in between the space, so the space between the radiohumeral joint. Relative rest, which is always difficult for our folks, but I just tell them, I know that you're going to have to do a certain amount of transfers, but minimize your activities over the next couple of days, and then start to work through range of motion and then strengthening exercises. Lateral epicondylitis, so tennis elbow, is often seen in our folks as well. And so this is one you have to be a little bit careful using a relatively small dose. You're going to pepper the tendon at the lateral epicondyle, and ideally use a tennis elbow strap to take off the pressure, or you know, at the point of, you've got the origin and then the insertion. So in this case, the origin of the extensor muscles, you want to take the pressure off of that by using a tennis elbow strap, especially over the next 5 to 7 days, and then gently start to move forward with range of motion, isometric exercises, moving on to more isokinetic types of exercises as you go through there. The medial epicondylitis, so we typically call that golfer's elbow, also treated fairly similarly. Now you've got the wrist flexors instead of the extensors that you're working with. Pepper along the tendon, relatively small dose in here, and still I use a tennis elbow strap, even though this is golfer's elbow. The whole point is you're trying to take the stress and strain off of the origin of the wrist flexors, and pick those up with the strap itself. So again, moving on to range of motion, and then isometric exercises before you move on to the isokinetic exercises. All righty, these are fun. These are the breaks, right? What would you call this fracture? Anyone? And maybe you're not sure.
Collies.
No, Collies is going to be
Smith.
more distal. Smith is going to be more distal as well.
Oh.
So this is the Monteja fracture. Ouch. Yes, and so typically is going to involve the proximal ulna, and you're going to have radial head dislocation associated with this. So you're not going to be able to manage this non-surgically. This is going to require open reduction internal fixation, and typically they're going to put a plate on here with screws as you move forward. Again, we see this a lot in able-bodied population, no big deal. You put them in a cast, put them in a sling, and life goes on, right? Not so much if they're a manual wheelchair user, because they are dependent upon these upper extremities for mobility and wheelchair propulsion. So you're going to have to quickly put your heads together with the orthopedic surgeons and the insurance companies and come up with an appropriate strategy for mobility during the healing time for this fracture. Oh, I already gave this one away, sorry. The Galeazzi fracture. So this is going to be distal as you're coming through. You've got distal radial fracture and a radial ulnar dislocation here. Again, this is going to require open reduction internal fixation with a compression plate, and be thinking in advance. You should already be thinking about, if you're going to be managing folks who are wheelchair users, what would they need if they sustain such a fracture? And again, recognize they're going to be non-weight bear on this for a certain period of time. So they're going to need some form of powered mobility and assistance with transfers during the healing time as we move forward on this. Okay. Now, somebody mentioned this before. It's not Lassie, but it is a, anyone?
Collie?
Collies, yes. Lassie is a collie, but this is the Collie's fracture that was mentioned earlier. And so this is often called the silver fork deformity. This is distal radial extension compression fractures. So you can see that happening. Again, going to require closed reduction sometimes, but most of the time open reduction, internal fixation, and then an external fixator as they're going through this. Minimum 6 to 8 weeks healing time afterwards. So you're going to have to provide some mobility and transfer options in the interim as you come through there. Somebody had also mentioned this one, not the Collies, but the
Smith.
Thank you. So the Smith fracture, was that Dr. Amarian Farr? So quietly in the background. So the Smith fracture is going to be just kind of the opposite. So this is the garden spade deformity. So again, a distal radial fracture, but now everything is going to be inferiorly displaced. The bottom line is it's going to require 6 to 8 weeks healing time and mobility and transfer processes that are going to be different than just using the upper extremities as they normally would. Again, I'm running short on time. I'm going to jump through this relatively quickly, but the films, all of you, I'm sure, are very familiar with all of the bones of the wrist and moving into the hands. That said, your next x-ray is probably not going to show up very well, but most of you would be able to pick this up as a snuff box.
Scaphoid fracture.
Scaphoid fracture, right. So basically what you worry about here is necrotic because you have such disruption to the blood flow through this bone as well. And so the middle third fracture is the most common. Again, you're going to need this immobilized for approximately 8 to 12 weeks in a thumb spica cast. They may tell you that they can do manual wheelchair propulsion and transfers. Don't trust them on this. Be ready to intervene because you don't want them to develop pressure injuries associated with these as well. Moving forward a little bit more, some of you have seen this, very painful, this migration as it comes through the scapholunate dissociation. You know, not too big a deal. Well, it is a big deal, even in the able-bodied population, but can be devastating in a manual wheelchair user. So typically associated with that is going to require significant surgical intervention, and again, 8 to 12 weeks of relative rest. First, MCP joint. This is another one of those injections you get almost immediate relief, and the person is so, they're your best friend for life once you've done this, because this is a very painful process, this first MCP joint, but with the appropriate injection, you can get them back to functioning within a couple of weeks, basically, back to normal if you do it appropriately. Wrist joint injection, again, if you, you're going to be working with these folks significantly, you're going to see this flare up intermittently. And so very satisfying injection for both you as well as the patient as you put it through there. Carpal tunnel syndrome, again, up to 2/3 of our folks who are manual wheelchair users will develop carpal tunnel syndrome, and recognizing that management, you can do an injection, we can try that. I know that they have other things to do as well. Again, can be relatively satisfying, but you're going to need to have them in carpal tunnel splints at night as this is resolving. And depending, they may end up having to use those during the course of the day, which significantly limits their mobility and functional transfers. De Quervain's tenosynovitis, what's the test that you look for?
Finkelstein.
Yeah, it's listed right there. So yes, Finkelstein's test. Again, this can be really problematic, particularly for factory workers and whatnot, but for somebody who's a wheelchair user, this can be almost devastating. And so trying to get them to rest, that's the hardest thing as we try to heal these, and relative rest is pretty difficult, unfortunately, with our wheelchair users. Don't have time to go into all of these, so I'm just going to run through them real quick. This looks like
RA.
Rheumatoid arthritis, absolutely, and we can see our typical findings here. This is the, why do they call it this? You're trying to pin a flower on
Boutonniere.
Yeah, Boutonniere's fracture. And then this one is going to be
Swan neck.
the swan neck deformities. So just recognize that these, if you have a manual wheelchair users developing these kinds of dysfunction, you're going to need to move sooner rather than later to powered mobility for them. Trigger finger injections can be, again, very, very helpful. Breaking down, remember, basically all you've got is a buildup of collagen as the tendon so that it can't slip through this. Can be very helpful. And this is Bennett's fracture, Pride and Prejudice, right? So Bennett's fracture basically at the base of the first metacarpal. And this is a Rolando's fracture. So now you're also looking at the base of the first metacarpal phalangeal joint as you're coming through. This is the boxer's fracture. And this is little avulsion fracture there called the mallet finger. Okay, as you're going through these. Gamekeepers are now, not many people are killing rabbits this way anymore. That's usually how these were found before. Now we see it as skier's thumb. And so you get this ulnar collateral ligament tear. And we try to prevent these and get back to happy days, which some of you may have heard of and many of you maybe not. I'm getting a little older as this goes through. So I didn't have enough time to go through this extensively, but I did want to show you these different things. Everything that you'll see in the able-bodied population, you'll see twice as frequently or more so in manual wheelchair users. And so just recognize that all these techniques that you're learning, musculoskeletal, sports medicine, are going to be very, very helpful for you if you go on and work with our folks with spinal cord injury. So I'll give just a couple of minutes for questions. I covered a lot of material very, very fast.
Thank you, Dr. Gator. I have two questions. First of all, how soon would you see some osseous changes at the shoulder after somebody starts overusing their shoulders, or they're a new SCI patient using a manual wheelchair? And the second question would be, you said earlier that we tried to avoid steroid injections into the tendon. However, for trigger finger, we're injecting the tendon preferentially. Can you just expand on that?
Sure. So the first one, I don't know. It depends on the relative overuse for these folks. It depends on the weight of their wheelchair and their body weight, and how many hits a day they're doing on their push rim and how many transfers they're doing a day. So generally speaking, young, healthy, athletic folks, we're not going to see those degenerative changes for 15, 20 years. However, somebody injured in their late teens, early 20s is very likely to start showing degenerative changes and significant shoulder pain, in their 40s, certainly by their 50s. And so we start having problems with that. Yeah, I don't want to weaken a tendon, and so I try to avoid injections to those tendons or use very small amounts, except for essentially you've got a collagen overdose in trigger finger type of a scenario. So there I'm trying to whittle it down. What the surgeons would do is just go in and shave the tendon down. We're trying to do the same thing with the injection. So generally speaking, you don't have the forces associated with those fingers down in the hand that you would otherwise, in the at the elbow joint, the shoulder joint, etc. So, but we're going to be using still relatively small dose of corticosteroid to try to manage that. All righty. Any other questions, thoughts, concerns? All right. Everybody have a wonderful day, and don't overwork your upper extremities.